Walker Intima Laser is an innovative laser platform dedicated to minimally invasive gynecological treatments. The laser system is tailor-made for any modern gynecological practice, allowing simple and fast in-office procedures with outstanding, clinically proven results.
Working with the high-tech quality of technology helped me in the past and now in the present to differentiate my practice, to have the possibility to offer to my patients improvement on their quality of life that cannot be achieved with any other tool.
Safe, tested, and proven solutions are available for a wide range of gynecological applications. From Fotona's revolutionary non-invasive procedures for pelvic floor disorders to the simple removal of lesions and high-precision cutting. Fotona's revolutionary and clinically tested gynecological procedures are preset for your convenience and ease of use.
Fotona procedures are very safe. The Smooth is intrinsically safe. After the use of Fotona lasers in few patients, I did realize right away that these procedures are very safe, very effective, and rewarding, also in terms of economical point of view.
The patented and clinically evaluated Fotona Smooth procedures are becoming the preferred treatment for pelvic floor disorders. Fotona Smooth is changing the practice of gynecology forever, with 70% of patients cured or showing significant improvement after 2 to 3 treatments.
Introduction of Fotona lasers completely changed the profile of our practice. I cannot be more happier that we made the decision 7 or even 8 years ago to start with the laser treatment of gynecological problems.
This dual wavelength laser system provides 2 complementary laser wavelengths, the ErYag and neodymium-YAG, for exceptional versatility, from gentle ablative to non-ablative thermal treatments. Top-of-the-line intuitive technological solutions provide ease of use with increased comfort and convenience for the operator. With the integrated G-Runner robotic scanner, we achieve exceptional accuracy, precision, and optimized treatment time.
Has laser changed my practice? Absolutely. That's how I started it off. You know, it was a walk-in, walk-out treatment. It was painless, bloodless, no anesthetic required, no infections, and most importantly, no complications really.
Time Walker Intima Laser delivers high precision, minimally invasive, clinical, aesthetic, and surgical procedures with exceptionally high patient satisfaction. Time Walker Intima Laser, the perfect choice for any modern gynecological practice. Time Walker Intima Laser is an innovative laser platform dedicated to minimally invasive gynecological treatments. The laser system is tailor-made for any modern gynecological practice, allowing simple and fast in-office procedures with outstanding, clinically proven results.
Working with the high-tech quality of technology helped me in the past and now in the present to differentiate my practice, to have the possibility to offer to my patients improvement on their quality of life that cannot be achieved with any other tool.
Safe, tested, and proven solutions are a range of gynecological applications. From Fotona's revolutionary non-invasive procedures for pelvic floor disorders to the simple removal of lesions and high-precision cutting. Fotona's revolutionary and clinically tested gynecological procedures are preset for your convenience and ease of use.
Fotona procedures are very safe. The Smooth is intrinsically safe. After the use of Fotona lasers in few patients, I did realize right away that these procedures are very safe, very effective, and rewarding, also in terms of economical point of view.
The patented and clinically evaluated Fotona Smooth procedures are becoming the preferred treatment for pelvic floor disorders. Fotona Smooth is changing the practice of gynecology forever, with 70% of patients cured or showing significant improvement after 2 to 3 treatments.
Introduction of Fotona lasers completely changed the profile of our practice. I cannot be more happier that we made the decision 7 or even 8 years ago to start with the laser treatment of gynecological problems.
This dual wavelength laser system provides 2 complementary laser wavelengths, the ErYag and neodymium-YAG, for exceptional versatility, from gentle ablative to non-ablative thermal treatments. Top-of-the-line intuitive technological solutions provide ease of use with increased comfort and convenience for the operator. With the integrated G-Runner robotic scanner, we achieve exceptional accuracy, precision, and optimized treatment time.
Has laser changed my practice? Absolutely. That's how I started it off. You know, it was a walk-in, walk-out treatment. It was painless, bloodless, no anesthetic required, no infections, and most importantly, no complications really.
Time Walker Intima Laser delivers high precision, minimally invasive, clinical, aesthetic, and surgical procedures with exceptionally high patient satisfaction. Time Walker Intima Laser, the perfect choice for any modern gynecological practice.
Oke, Assalamualaikum warahmatullahi wabarakatuh. Selamat malam dan selamat datang kepada peserta yang sudah hadir. Selamat datang di acara webinar malam ini yang bertajuk Efficiency of Non-Ablative Erbium Laser for SUI and GSM by Fotona. Pertama-tama, saya ingin memperkenalkan diri. Nama saya Fasyalia. Saya adalah marketing representatif dari PT Admiral Blesensa Abadi. Sedikit penjelasan untuk dokter-dokter, mungkin ada beberapa dokter yang sudah mengetahui perusahaan kami, ada juga yang belum. Jadi PT Admiral Blesensa Abadi, perusahaan kami adalah perusahaan distributor tunggal laser Fotona di Indonesia. Dan acara webinar pada malam ini merupakan acara seminar dan webinar lanjutan dari webinar-webinar yang sebelumnya pernah kita laksanakan. Kita biasa melaksanakan webinar tentang laser Fotona dengan speaker yang berbeda dan juga judul yang berbeda-beda. Lalu selamat datang lagi saya pastinya untuk para peserta terhormat, para dokter, profesor, dan juga terima kasih untuk peserta yang sudah hadir. Lalu selamat datang juga saya ucapkan kepada moderator yang sudah bersama kita pada malam hari ini. Malam hari ini kita kedatangan Dr. Alfa Meutia. Selamat malam dokter, terima kasih untuk waktunya dan kehadirannya sebagai moderator pada malam hari ini. Dan juga kita kedatangan 2 speaker pada malam ini. Currently we have 2 speakers. Good morning. For Dr. Adrian. Dr. Adrian is currently in Miami right now, so it is morning from him. And also good afternoon for Zdenko from Fotona. Thank you so much for your time. Thank you for becoming our speaker. And then lalu seperti yang sudah saya jelaskan sebelumnya, pada malam hari ini kita akan menggelar webinar. Rundown-nya adalah yang pertama akan dibuka oleh presentasi dari Zdenko, lalu selanjutnya akan dilanjut oleh presentasi dari Dr. Adrian yang akan dimoderatori oleh Dr. Alfa, dan di saat presentasi berlangsung peserta bisa mengirimkan atau menanyakan pertanyaan tentang topik webinar di dalam question box seperti itu. Lalu informasi lain untuk peserta, di dalam flyer disebutkan bahwa peserta akan mendapatkan e-sertifikat. Pasti peserta akan mendapatkan e-sertifikat, tetapi perusahaan kami hanya akan memberikan sertifikat kepada peserta yang mengikuti webinar sampai akhir. Nanti link untuk mengisi sertifikat, link untuk evaluation form-nya akan saya kirimkan kira-kira 10-15 menit sebelum acara berakhir. Oke, sebelum webinar saya serahkan ke Dr. Alfa selaku moderator, saya ingin membacakan terlebih dahulu CV Dr. Alfa. Mohon ditunggu sebentar. Oke, saya harap para peserta bisa melihat ya. Sebentar. Oke, Dr. Alfa P. Meutia. Beliau, edukasi yang sudah beliau tempuh adalah beliau pada saat ini beliau sedang menjalani edukasi di PhD Doctoral Program in Medical Sciences di Faculty of Medicine di University of Indonesia di UI. Lalu beliau pada tahun 2017 dan 2018 juga merupakan fellowship on mesh augmented, mohon maaf apabila ada penyalahan penyebutan, fellowship on mesh augmented and advanced urogynecological surgery di Kameda Medical Center, Jepang. Lalu beliau juga aktif di berbagai macam organisasi kedokteran, yaitu yang pertama seperti yang bisa dilihat ada Terminology and Standardization Committee of International Urogynecological Association juga, lalu juga beliau merupakan member dari HUGI, PERKINA, POGI, dan IDI. Oke, saya akan menyerahkan webinar ini ke Dr. Alfa. Untuk waktu dan tempat saya persilahkan, silahkan Dr. Alfa. Dr. Alfa, sepertinya ada. Dr. Alfa. Halo Dr. Alfa, bisa dengar suara saya? Halo dok.
Halo.
Halo. Yes, saya bisa dengar suara dokter. Halo.
Pasha?
Yes.
Ini terputus. Ini sudah mulai?
Iya. Bisa dengar suara saya?
Ya. Shall I start?
Okay. Yes, sudah saya bacakan CV dokter. Silakan ya dok. Terima kasih.
Halo Fasya.
Dok, sudah bisa dimulai.
Zdenko, can you hear my voice?
Yes, Fasya, I can hear you well.
Yes, maybe Dr. Alfa is having some issues. Hello, Dr. Alfa. Can you hear me?
Pasha, yes, I'm trying to connect with another device.
Okay, so
Wait.
I already read your CV, ya, Dok.
Yes. Oh, I think this.
So shall I start?
Yes.
Wait. Okay. So good evening to all participants, and also maybe good morning or good day in some part of the world, and also good morning to Adrian and good evening to Zdenko. Thank you again, Fasha, for the kind introduction. So for now, I think we just start on the according to the rundown. So we will have two presentations by two esteemed speakers, Zdenko Vizintin and also Dr. Adrian Gaspar. Both will give topics regarding the use of laser, especially in gynecology, managing the genitourinary symptoms of menopause, and also for stress urinary incontinence. For the first speaker, Zdenko, will give a talk about how the use of the Fotona Smooth. Fasha, are you going to start? Yes, please. Okay. So Mr. Zdenko Vizintin has been working in laser technology for more than 40 years. And throughout his professional career, he has been deeply involved, especially in the production of various laser systems for different industries. His current position in Fotona is as Medical Laser Program Director and responsible for the application, development, and clinical affairs. Without further ado, to Zdenko, please, the time is yours.
Thank you very much. Thank you very much, Alfa. I just would like to ask Fasya if she can make me a host that I can share the screen. Hello, everyone. Good evening to all the participants from Indonesia. I know it's already evening in your country, and I hope you will stay with us until the end of this short webinar. My talk will be about 40 minutes, and as soon as I got my host right, I will start with presentation of my talk. So I hope you can all see the screen, safety of laser in gynecology. And let's start. So as you can see, I start from the very beginning. I know that some of you already know lasers quite well. Some of you maybe worked with laser, but probably there are also some people who didn't work with laser yet. So laser become so very common word that some people even didn't know it's an abbreviation. It's an abbreviation for light amplification by stimulated emission of radiation. It's a very specific light. This light never existed in the nature by itself before the human invented it. So when we talk about light, we have in mind mostly this visible part of the light, which our eyes can see. But in fact, as you will see through my talk and later, the laser which we are using are invisible, in fact, for our eyes. They are working in a near infrared region. Just one more information, when we are talking about the type of laser, we are using the wavelength as a measure, and this is expressed in length, and usually in nanometers. And nanometers is 10 to minus 9 of meter. It's very small. If you go from meter, you go to millimeter, micrometer, and nanometer. So here you can see a lot of markings of different abbreviations of lasers through the visible part of spectrum, ultraviolet part of spectrum, infrared part of spectrum, and so on. So lasers can be produced in all of these parts of spectrum. And the laser about which we are talking today is called ErYag, and its wavelength is 2,940 nanometers. and it is sitting here on this slide. So it's a mid-infrared wavelength. Why ErYag? Why we are using ErYag for this procedure? This is a very specific laser, very specific wavelength. This particular wavelength is the best absorbed in the water absorption curve. If you look into this black curve here, it's absorption curve of water. This is where the light spectrum lies, and this very peak here is where ErYag laser 2940 is sitting. And because it is so well absorbed in water, it is matching, actually it is perfectly matching the vibration frequency of the molecules of water, which means that the smallest quant of ErYag light will cause here amplification of this vibration and then breaking up of the molecule, causing vaporization of the water. So it's a perfect fit for water absorption. It can work in different regimes, and most of people knows this kind of lasers as ablative lasers. We can achieve cold ablation, like drilling the hole in the tissue or taking away part of tissue. But with the special modification of packaging of energy into the pulses, we can do also ablation plus coagulation, that the part of the beam will be spent for warming up. Or we can do totally non-ablative coagulation of the tissue without ablating and moving away the tissue. So there are different modalities of using it. And regarding the optical penetration of laser light into the tissue, when we are talking about different lasers, we can see here on this graph, this is a skin, how different wavelengths are differently deep penetrating the tissue. And this penetration means how far the photons of the laser light will come before they get captured into the molecules of water or maybe some other atoms, and then contribute their energy to these molecules or atoms. So neodymium-YAG 1064 is penetrating the deepest. We can say it's a centimeter range. And here on this side, just because of very high absorption in water, if you remember this curve here, there is a high absorption of water and not so high here for neodymium. So because of this high absorption, these wavelengths there are not very deep penetrating optically. So ErYag and also CO2 laser and also whole beam YAG laser, they are actually very shallow in penetration, in optical penetration, but they are excellent for absorption, vaporization, and cutting. Now in the gynecology, we have different lasers used, predominantly these two, CO2s and ErYag. Sometimes there are discussions about penetration, and when people try to show that CO2 is penetrating deeper, they are showing this part of the graph. They are showing optical penetration. It is true that the CO2 is penetrating deeper optically, but none of these two has important optical penetration. They are very shallow, both of them. And actually, this kind of mechanism is not used in the protocols which we are forming for treatment in gynecology. What is used for CO2 is mostly this one, ablation. So how deep you can drill the hole, it depends on intensity. Mostly it is called fluence density of energy, and it is not dependent of wavelength. So CO2 and ErYag, both of them can penetrate equally deep when they ablate the holes, which is one of the modalities used in gynecology. But in the case of Fotona Smooth, we are using the third way of interaction, and this third way is the penetration through the heat diffusion. So what we are doing, we are warming up the tissue here. We are warming up, but this heat is penetrating deeper and deeper, and it is doing changes in the tissue through the mechanism of hyperthermia, mostly of collagen, but also in vascular structures, as I will show you later. So we have three different mechanisms of actions. We have optical penetration of the photons before they are absorbed. We have possibility to drill the holes in the tissue, or if you have this possibility, you can also do treatment by thermal diffusion. So when someone is talking about depth of penetration, you have to ask them what of this interaction they are talking, what they have in mind. If they have in mind this kind of ablative treatment, you cannot compare it with optical penetration. And this is what in most cases people are doing. They said, oh, my laser is penetrating very deep and yours is not going very deep. This is just misunderstanding of concept. So let's go to the safety of lasers in gynecology. So when we are talking about treatments in gynecology, I start to use this graph, which was designed by my good friend Sabina Senčar. She's a gynecologist here from Slovenia, from Ljubljana. And when she started dealing with lasers, she made this graph. So what you can see here are treatments which can be regarding the invasiveness, non-invasive or invasive. And then you can see tissues which are treated. They can be muscles or connective tissue. So this is a classical approaches. You can see here non-invasive treatment for muscles, like Kegel exercises, some electrostimulation, and so on. Invasive treatment, of course, different surgeries. Surgeries for muscles, but also surgeries for connective tissue. And here in this segment of non-invasive treatments for connective tissue, before we started with lasers, there were nothing in it. Looking back historically, you can see here 20 years ago, we started to use ErYag in a surgical mode, ablative vaporization mode, for cutting, removing different lesions from the cervix. This is an article in Spanish from 2001. This is one of our first presentation on Medical Congress in 2001 when we are showing surgical procedure on cervix. And also you can find even now quite some articles and clinical descriptions of protocols for removal from cervix, different lesions, or removal of condylomas and other stuff. So this is a surgical use of lasers. And this falls into this window here. So it's invasive, it's surgical for connective tissue in this situation. And then 10 years ago, actually what we introduced is our Fotona Smooth ErYag treatment. The first publication you can see here was also in Spanish. It was in Latin America, where the doctors were showing what they are doing with our laser, and they call it rejuvenation, vaginal rejuvenation with laser. And my first presentation was on symposium in 2011. So you can see it is 10 years ago. And what we do, and this is a topic of today's webinar, we are using our lasers to treat different indications in pelvic floor dysfunction, like stress urinary incontinence, pelvic organ prolapses, vaginal laxity, and so on. And also, of course, for a very big group of indications like genitourinary syndrome of menopause. But this is not all what this laser can do. It can do much more. It can do a lot of aesthetic treatment in gynecology. It can do a lot of good result in chronic infections, vaginal chronic infections, and there is other gynecology here, and this field is quite wide, in fact. So looking back to this graph, we now came into the area where we can use a non-invasive way to treat connective tissue with a smooth ErYag, or also there are other manufacturers doing ablative CO2. And then last year, actually, we introduced a new energy-based device into the use in gynecology. It's not a laser, it's a magnetic chair. And this magnetic chair can be used in a really minimal invasive way for the range of applications, starting from stress incontinence and so on. And this fills this window here. So it's a non-invasive treatment of muscles. With laser, we can treat connective tissue. And if we do not do surgery, of course, you can cut muscles with lasers, but this is not popular. So in fact, with the energy-based devices in a non-invasive way, we can treat muscles with magnetic stimulation, and we can treat connective tissue with a smooth ErYag or some other ablative lasers. So let's concentrate just on this Fotona Smooth today. What it is, this is a diagram which I'm usually showing. This is a conceptual picture of Fotona Smooth. We are not delivering one pulse, but we are delivering the train of pulses. And each of these pulses is subablative. It doesn't cause ablation. It contributes some heat by absorption. If we look here, this heat is spreading down. With every of these consecutive pulses, micropulses, a new heat is added, and this head is going deeper and deeper. It can reach up to, let's say, 500 microns, where it do the hyperthermic changes. This is our graph about temperatures on the surface, which we are achieving with this kind of modality. This is our stacking of pulses, one smooth mode pulse, second, third, fourth, and we can very precisely dimension how high we would like with the temperature to come with the temperature, and we are usually not going beyond 60, 65 degrees, which are still tolerable by the patients on mucosa, and on the other side, it doesn't cause any irreversible changes on the collagen. When we were studying the effects of our smooth pulse, we discovered that it is not only standard hyperthermia, which is a relatively slow thermal process, but also because of these micropulses, we have an additional effect, which we call fast heat shocking. And this effect showed to be also very beneficial. And it is again unique for ErYag because of this feature of best absorption in water and short optical depth. Only ErYag can produce this very high peak short time temperature spikes, which are causing some processes inside the tissue which are beneficial. So slow thermal heating is very well known for many years now. People can do this on different waves. You warm up the tissue and then tissue start to change according to the temperature. So what we see with this part of mechanism, we see these three interactions: photothermal, thermomechanical, and also neocollagenesis. And again, this is an old picture of mine, which is already published several times, in which I'm explaining, if you look into the cross-section of vaginal wall, this is vaginal wall structure, epithelium, lamina propria, muscularis, adventitia, fascia, where this heat is going. When we are doing smooth mode, there is a temperature which is spreading through epithelium to lamina propria. So just in this area, it's 0.5 millimeter. You can consider the thickness of this vaginal wall between, let's say, 2.5 and 4 millimeters, depending on let's say, situation of patient. And what is happening when this heat came to this area, it caused shrinkage of the collagen. So you get immediate shrinkage of the collagen, and this shrinkage on the surface is causing mechanical pull of lower laying structures. This is where this photomechanical effect came into the play. And this is momentary effect. And then through time, up to 6 months, what is happening post this hyperthermia is a chain reaction in which heat shock proteins are involved and the fibroblast and so on. So we are getting a new collagen. It's called neocollagenesis. And this neocollagenesis is causing the thickening of the vaginal wall, which is becoming thicker and stronger and healthier, like you can see on this clinical picture. This is one cystocele, one prolapsed anterior wall before the treatment and after the treatment. You can see the changes on the tissue, including this ruges coming out. And when you do the test by palpation, you can feel it, that it is more elastic, more strong. How strong are these effects? We measure in some initial studies. We can say that this shrinkage is coming to quite large millimeters. It's in average about 12 millimeters of shrinkage, and which represents about 17% of the total size. But again, this is dependent on patient ages, on genetics, on some previous scarring or not. Some patients, younger patients, can get even up to 30% of shrinkage, and some older patients maybe just 5%. But in any case, we have this shrinkage of collagen. Existing collagen goes to the shrinkage. And the thickening of vaginal wall, we also measured with the MRI imaging of the cross-section of vaginal wall, and we find out that it can get even 1.5 millimeter in average of thickening, which would represent more than 50%. So these effects were studied. They were also published. We have some histological studies also published. One is by Adrian, our good friend who will be talking after me. Maybe he will mention it. So it's a very well-known mechanism. The secondary mechanism, which is also present always after the hyperthermia of the tissue which has any vascular structure, as lamina propria is, we will have also neoangiogenesis. We will have creation of new vascular structure, new vessels. There will be the stimulation of vascular growth factors, and then the whole process will go like in neocollagenesis, it will go here in neoangiogenesis. This was also observed in histological samples and also published already in, I believe, 2 or 3 papers. Just a few words about this component of fast heat shocking. It's a novelty. We just discovered it maybe 3 or 4 years ago. And in fact, it has indirect biochemical interaction with keratinocytes, and these keratinocytes, which are on the surface, they start to communicate with fibroblasts via so-called paracrine signaling. So this paracrine signaling is also very well known. This is events which are happening on the level of cells. It's not a very fine reach. It doesn't have a very long reach like endocrine signaling, but paracrine signaling is helping in the wound healing process. And in this particular case, with irradiation with smooth mode, it is helping with the changes in a tissue, in epithelium, and lamina propria. So if someone is interested to learn more about these mechanisms, we have 2 articles published. Both of them are open access. So this is the one, dual tissue remodeling, non-ablative resurfacing of soft tissue with Fotona Smooth. And this is the second one, which was published in American Journal Laser in Medical Science, variable heat shock response model for medical laser procedures. It is more, how to say, not only theory, it's also shown by experimental results, but if it is just for people who are really interested in physical background. However, we noticed even before we recognized these short and high heat shocks that people from different fields of medicine were reporting about the healing power of ErYag. They usually didn't have the explanation why it is happening, but this is just an example of article, and they see a novel explanation for the healing effect of ErYag during skin rejuvenation. Or, for example, this one, biological effects of ErYag laser, and so on. There are quite some, I would say, at least 10 different articles from fields from dentistry to dermatology in which people are noticing that ErYag has a specific healing power. So these are all the reasons why we selected to use ErYag in non-ablative way for our gynecological procedures. So how we use it? This is a laser in which we are using ErYag, but also Antiaging. Now today we are talking just about ErYag. We have a specific delivery tools with which we deliver the laser beam inside the vaginal canal, and we can shoot it either perpendicularly, just with the angular mirror upwards, or we can shoot it circularly to cover the whole canal. There are different versions of these tools. We started with the metallic speculums, which are very robust and nice. But through time, we went into the glass one. It's a quartz glass, which is transparent for erbium light. So there is no obstacles here to pass through. And this is a big difference, for example, to CO2 laser. CO2 laser cannot pass the glass. They cannot use this concept of glass speculums, except if they make a hole for the beam. So glass speculums are now the most commonly used. And several years ago, we also launched this robotic probe. It's a special scanner which is doing the protocol by algorithm. So it's very easy for the users to apply the procedures, because you just press the button, step on the foot switch pedal and shoot the laser, and the mirror and the beam are going through the protocol according to the algorithm. It's very nice, it's easy and quick. And lastly, we are the only one on the market which has this possibility to introduce the laser light also into the urethra and treat the applications like is intrinsic sphincter deficiency or atrophy of the sphincter. This small cannula is delivering smooth mode erbium inside the urethra, where we are doing again hyperthermia. Some of our competitors tried to copy this idea, but their energy was too aggressive. So they produced some injuries and they abandoned this idea. So the only possibility to treat with the laser by hypothermia sphincter, urethral sphincter in female is using Fotona Smooth technology. So altogether, talking about technology, these are all the tools which we are using aside of lasers. So we have some hand pieces to deliver full beam, fractional beam, and then some speculums and adapters for bending the beam, robotic probe, and intraurethral probe. I'm sure Dr. Gaspar will be talking more about this when he will present particular applications. The history of use of lasers in this minimally invasive way for the connective tissue started somewhere in 2010. There were two systems appear in this period of time on the market. One was our ErYag, and the other was one CO2 laser. And first 3 years, we were the only players on the market until the other noticed that there is a big potential, that the results are great, that it's minimally invasive without much side effects. So other people start joining. And in fact, you can see that in this period from, let's say, 2014 to 2017, 18, there are actually a lot of other players entering this market, more of them in CO2 arena because it's a simpler and cheaper laser, but also with some radio frequency tools and some high intensity focus ultrasound as well. This is my list from 2017 of the manufacturers. You can see here about maybe 35, 40 manufacturers, and there are different energy-based devices. This EBD stands for energy-based device, like lasers, radio frequency tools, and high-intensity focus ultrasound. So if you look into these products, there were like 25 CO2s, 5 ErYags. I must say, out of these 5 ErYags, only Fotona Smooth is non-ablative. The other 4 are practically using the same mechanism as CO2. They are doing ablating drilling. There were also 2 diode lasers there, and then a few radio frequency and just 1 HIFU. Nowadays, there are even more because this development is continuing and more people are entering this field because it's very attractive considering the results and the minimal invasiveness. However, from the very beginning of appearance of these lasers on the market, there was discussions and doubts about it. This is a picture slide from the TV show, American TV show, The Doctors, in which the moderator was asking some doctors, can laser really fix incontinence? There are big doubts about it. You can also find some articles in which people were asking themselves and also the others, do we have enough evidence that vaginal laser therapy for stress urinary incontinence is really working? And then there were others which are looking into the critical appraisal of the evidence, being cautious if this is really working. And some people were warning, please do not make mistakes like we did in the past. What they have in mind here with past mistakes are slings, different tapes, which are now taken out from the use and so on. And what happened in 2018 is actually, it was like a cold shower for this industry because FDA issued a warning against the use of energy-based devices to perform, but please take care about the term, vaginal rejuvenation. It is the term which is not a medical term because what does it mean, vaginal rejuvenation? It's tricky definition. And after this warning, which they sent also to 7 particular manufacturers, a lot of people become even more cautious to use the energy-based devices for these gynecological applications. These manufacturers here, they were listed and they were directly warned by letter because they were doing inappropriate marketing in US, and they were claiming that this laser also, these devices has also FDA certificate, which was lie. No one has yet FDA certificate to be used for non-invasive procedures for, let's say, stress urinary incontinence or GSM. Although our laser and also some other lasers has approval to be used in gynecology for different procedures, but not particularly for SUI or GSM. So what happened after that and why actually they issued this warning? Because they got some complaints, very small, I would say, level of complaints of some patients. And these complaints are usually collected in so-called MODE database. This is a medical database in which some side effects were recorded. And this is one of the sources for FDA to take a look into it. And this is an article which was published immediately after this warning. And this was by a group of American doctors working a lot with lasers. So they are laser connoisseurs. So what they did, they made a cross-sectional analysis of this database for the period of 4 years, 2015 to 2019. And what they found is just 45 distinct events describing 46 patients. And there were like patient-related injuries, just 39. And which were these injuries? This was like a pain. It's not injury, in fact, it's complaint. It's a pain or burning or numbness or scarring or burns, dyspareunia, and so on. So relatively low level. Firstly, the number for 4 years is extremely small. Secondly, the level of these injuries or side effects were relatively mild and transient. However, of course, some people reporting about some of these effects. This is an article from 2019 by a group of American doctors in which they were reporting about 4 cases only, in which there were complications after completion of 3 consecutive laser treatments for GSM. I must emphasize here that all of these 4 cases were done with ablative fractional CO2 laser. But anyhow, 4 cases were described in which there were some complaints. And this was a complaints like a wall laceration, resuming the intercourse after the treatment, and some persistent dyspareunia, worsening dyspareunia, and some interstitial pain. All of them were solved. So these are not very life-threatening or whatever side effects there. Let's take a look into some pictures how the tissue looks like after the treatment of different technologies on this market. This I took from an article where one manufacturer of fractional CO2 ablative laser was showing the pattern of the micro wounds they are producing. You can see here just a drop of blood, so otherwise bloodless, how it looks like immediately after. The other is more serious. So this one I would say is quite okay. This is not okay. Although this all solves in about, I would say, 10 days to 2 weeks. This is one cheap CO2 laser. It's a copycat of the good ones in which you can see some bleeding, you can see some burns. So this is burns here happening. So in my opinion, this is not okay, but this manufacturer considered this situation as normal and desired. The third one was also published, and in this one you can see here bleeding after drilling with the CO2 laser. This is also CO2.
Sorry to interrupt. You have 5 minutes more.
Okay, thank you. I will try to speed up. So here also you can see that they are showing some blood coming out from this intervention. And this is one case of our good friend, which will be talked after me, when he was using also CO2 in past, where there is a more significant burn here, which was also solved. But these were the side effects which were noted. And I succeeded to get this picture as well. This is from one diode laser. Diode laser can be quite difficult to handle properly. And you can see this was quite, I would say, cooked tissue, which again, this manufacturer considered okay, but it is not okay. And in fact, this manufacturer disappeared from the market. Here are a few pictures, what you can see after the use of Fotona Smooth. Actually, you cannot see nothing because it's non-ablative. There is no drilling, there is no hole, there is no bleeding. So it's just mucosa which have been thermally processed. And now to make a comparison with the previous report, this is also a MODE report published by FDA in 2014. On the period of 5 years, you can see 2005 to 2010, where they reported about almost 4,000 reports of injury, death, and malfunction. If you remember, with laser, it was 45 only, so it is 100 times more. And among these almost 4,000 reports, quite some of them were severe injuries and even death. So I would say it's a big difference in aggressiveness of these surgical procedures with meshes with the non-invasive lasers. And people noticed that. So this FDA warning was not passed unannounced, and the people start to comment it in many ways. This is an article from last year where a quite large group of American gynecologists were analyzing the situation, and what they said. This is Menopause Journal. I'm sure a lot of you know this journal. They said that the FDA safety communications appear unsubstantiated, and there is a well-documented benefits and low risk of adverse effects, which suggests that laser therapy for GSM is reasonable with appropriate pre-treatment counseling. So they support the use, and they were criticizing this, what FDA says. The other article also from last year from American Society for Urogynecology, they made a clinical consensus statement, and also they find out that ErYag laser and CO2 laser have shown promise in treatment of vulvovaginal atrophy with the benefits lasting up to a year and safety outcomes. It's a very good safety profile. Also, some other societies start to accept the use of lasers in gynecology. This is the latest guidelines for Italian Society for Menopause. And you can see here that they introduce laser therapy as one of the possible therapeutic treatments. So laser therapy is confirmed and accepted by the Italian Menopause Society. Here, just the latest one in December 2020, it's a Swiss expert group. They were analyzing different new treatments, including the GSM and SUI with laser. And you can see that they give recommendation A for GSM. They said evidence level 1B. And for incontinence, recommendation B, evidence level 2B. Both of these treatment with laser, they recommend to their users. I was invited in this year to participate on a roundtable discussion with the National Institute for Health and Care Excellence of UK. And they had different topics on agenda, but two topics were about lasers: transvaginal laser therapy for stress urinary incontinence, transvaginal laser therapy for urogenital atrophy, GSM. So they are now in processing, and I'm sure in the next meeting they will accept at least GSM for normal use as a standard procedure. Some of you maybe know this lady. She is Professor Linda Cardozo from King's College Hospital, a very famous urogynecologist, one of the most important key opinion leaders. And last year on the ICS meeting, she had this lecture, what is the role of laser therapy in genitourinary syndrome of menopause? And her conclusion were, there is a sufficient and growing robust data on the use of laser for GSM. Laser is as efficacious as long-lasting as current standard treatments, meaning hormones. And laser is now being offered as the first-line treatment for patients with GSM, so in her King's College. So more and more societies are accepting laser therapies in gynecology. We did safety surveys, and this is with what I will conclude my talk, just a few slides more. Our first survey of safety was done in 2014 on a relatively small number of patients yet, but not so small, almost 1,000 in 6 clinics. And this is what we discovered. We discovered there is some edema, which is normal consequence of hyperthermia, some pain during the treatment without anesthesia. Where you do it is like a grade 3 on the scale to 10, so it's very tolerable. There were some post-op pain for several days on small number of patients. Mostly these were GSM patients. Some superficial burns, which were caused by users. It's a human error, but very small number, and they resolved very quickly. Some pinpoint bleeding, and this is happening mostly in atrophic vaginas, where the tissue is tiny and it is cracking easily just by insertion of speculum. There was also some strong vaginal discharge notice. After edema, you get this definitely, but it is very short lasting and it is not so problematic. And there was also some de novo incontinence cases, similar like after sling surgeries. Altogether, there were rare, transient, and mild the side effects. Meanwhile, from 2011 to today, we published a lot of papers showing the efficacy of safety of Fotona Smooth. I don't have time to go through them. I will just show you some titles, and If someone is interested, Fascia can deliver you all of these papers. Probably Adrian will be talking about some of them. Altogether, in this moment, we have 75 clinical studies published in all of these papers, some of them very important papers, world important papers showing efficacy and safety. In 2016, when we already have 31 articles published, we did actually, again, the survey of the side effects reported. Again, what you can see here, cumulative frequency very low, vaginal discharge, spotting, the no incontinence, births, and so on. Nothing serious, everything was small and transient. And lastly, after this FDA warning, we decided to make a global survey. So we started this global survey in 2018. We finished it in 2019. It was global. We got response from all continents, in fact. And it came from 43 countries and reporting about more than 113,000 patients being treated with Fotona Smooth. Of course, there are much more users, and there are 535 clinics reporting here. It is probably 1/6 of all clinics having our laser. So the total number of patients treated, in my opinion, is more than 1 million, and maybe even today 2 million. What is the result of this survey? Again, there was a little bit longer list, but if you look into this top 4 here, vaginal discharge, edema, pain during the treatment, pinpoint bleeding. This was like 1%, 4%. Everything else very, very low. So most practitioners are considering this top 4 mentioned here as a normal reaction to treatment and not as an adverse effect. So it is an additional proof of safety of non-ablative smooth mode erbium laser in gynecology. And this survey was published 2020. It is an open access article. Everyone can download it and read it, and you can see what I'm talking about. It became also quite well known around the market. You can see this was invitation to the webinar in which this particular study was mentioned, and they said this is the largest vaginal study ever done. It was done with Fotona Smooth laser. Just one more small detail. We did also a study in which we were analyzing, does the vaginal erbium laser affect subsequent vaginal deliveries? Namely, if you have young patients which are still in reproductive period, and if they have treatments, for example, for vaginal laxity, and then they get pregnant and deliver, we were asking ourselves as well, what will be the effect by laser? And what we find out is actually that laser is even improving the tissue. So it's a safe option for treating premenopausal women between deliveries. No problem with that at all. This is unique paper. Just we have it so far, but I'm sure someone will do maybe something similar in future. So to conclude, lasers used in gynecology for various vaginal procedures in past 10 years are well clinically proven to be efficacious and safe for vaginal treatments. All adverse effects noticed so far were rare, mild, and transient. And please bear in mind, not all lasers are same, even if they have the same wavelength. Some other erbium YAGs using ablative treatments are having totally different effects than Fotona Smooth. Thank you very much for your attention.
Thank you, Zdenko. It's a very comprehensive presentation, and I think highlighting on the safety of lasers in gynecology use. I think we'll get back to you after this, because then following the discussion. For any questions from the participants, please feel free to put it in the Q&A column, and we'll get back to your questions during the Q&A session. For the second topic from Dr. Adrian Gaspar. So he will deliver the topic of, the efficiency and also safety of the use of laser for stress urinary incontinence and genitourinary syndrome of menopause. I think I do agree that we need to avoid the term of vaginal rejuvenation, as it has no matching medical term to it. So I think it's better just to use directly the symptoms that we want to relieve by using the lasers. And this is what we're going to talk about in the next topic. So how laser can relieve the symptoms of genitourinary symptoms of menopause and also stress urinary incontinence. Dr. Adrian Gaspar is an OBGYN specialist, cosmetogynecologist, former professor at the Gynecology Department of Faculty of Medicine at Mendoza University, Argentina, and an owner and director of the Espacio Gaspar Clinic of Gynecology Antiaging. Wow, great. With more than 15 years of education experience in the use of lasers in medicine, Dr. Gaspar has performed more than 1,000 vaginal laser procedures and has trained more than 700 worldwide. Wow. He is among the pioneers in laser treatments for vaginal rejuvenation, and having published the first paper related to the topic in 2011. Let's hear his presentation. And don't forget to put your question in Q&A column. Adrian, the time is yours for 30 to 40 minutes, please.
Well, thank you very much, Dr. Alfa. It's a pleasure for me. It's my first time lecturing virtually in Indonesia. I hope to visit your country in the near future. Well, I'm going to share my screen if you allow me the possibility, because I can't.
Wait. Fasha will make you the host again, I think.
Okay, yeah.
Fasha, can you help?
She needs to switch the host.
Yes.
Okay, in the meantime, I can start by saying that, yeah.
Wait a minute.
Okay, Adrian, you're the host now.
Okay, there we go. Excellent. Well, again, thank you very much. I'm going to talk about my experience actually using this amazing technology that Zdenko has just introduced. The title is Efficacy and also Safety. We have been talking about safety of this non-ablative, I would say, unique pulse of ErYag laser on the market for the management of these two conditions. Stress urinary incontinence and genital urinary syndrome of menopause. This is some societies who I belong to. My practice features actually cosmetic gynecology and anti-aging medicine. I'm an OBGYN, but I've been doing functional, regenerative, and aesthetic gynecology for the last, I would say, 12 years. So I decided to start my lecture by introducing the concept of something that gynecologists don't know, which is the concept of regenerative medicine. It's a broad field that includes research on self-healing, in which the body uses its own systems, sometimes with the help of certain simulation, to repair, to regenerate, or create cells and rebuild tissues. This is basically what regenerative medicine is, and it's been applied in many different specialties. When we apply this concept to gynecology, we call regenerative gynecology. And regenerative gynecology involves medical procedures that aim to improve or repair the histology and functions of the genital area. And we have to say that to date, a wide array of procedures have been described. So when I started doing all these treatments, nothing existed, I would say, 15 years ago. Now you will see that we have a lot of not only tools, but also procedures, surgical and non-surgical procedures to improve our patients' quality of life. So I would like to say that to highlight the importance of lasers in medicine in general, because gynecologists pioneered the use of lasers in medicine along with dermatologists. And in my personal opinion, is the only tool that allows us the possibility to be selective. Because when you use a radio frequency, when you use an ultrasound, you are warming everything. You're not targeting what we need to target. We understand that we need to target the mucosa. So lasers in general is the only tool, because laser has have a chromosphere, which is the target in which the photothermolysis effect will start all the changes and the outcome in the future. So its presence in terms of applicability is enormous, but its future in regenerative gynecology is more than promising. This is my personal opinion. So gynecologists again pioneered the use of lasers in medicine, because the laser was invented in 1960, 1961. Dr. Goldman, which is considered a dermatologist, which is considered the father of lasers in medicine, started using lasers for a ruby laser for to develop the photothermolysis effect. But a couple of years later, in Israel, another gynecologist started using the only laser available for medical purposes at that time, which is the carbon dioxide laser. And this was Dr. Kaplan, who published the first paper demonstrating the efficacy of the use of this ablative laser to destroy lesions at the level of the cervix in the uterus, to destroy lesions, warts, condylomas, HPV lesions, etc. But at that time, lasers were not approved. They were approved by the FDA in the United States in July 1978 for a vaporization, coagulation, incision, and excision. So for surgical, basically for surgical uses, as Zdenko has just showed to us. In the 80s, in gynecology, appeared other lasers for applicabilities like argon laser, KTP laser, and ErYag laser, but still the carbon dioxide laser remained the most popular for surgical, only for surgical uses, for vaporization. And I have to admit that from the very first beginning, when I was studying medicine in Argentina, I was attracted by this promising technology. In the late 80s and the early 90s, the full field ablation for facial rejuvenation are raised with long painful recovery and significant morbidity, mostly using a CO2 laser and another wavelength that appears ErYag laser, but as Zdenko has showed to us, for ablative purposes. If we have to mention how all these stories started, we have to mention that in the late 90s, Dr. David Matlock in California, in LA, in the United States, introduced the concept of laser vaginal rejuvenation. Actually, what was he doing at that time? He was just doing a labioplasty, a vaginoplasty, but he used a diode laser, which is a laser to cut tissues. So what he was doing was reconstructive surgery, and he called this laser vaginal rejuvenation, but actually was not doing any no regenerative effect. There were just a surgical correction. In 2003, Dr. Rox Anderson, a dermatologist in the United States, introduced the concept of fractional photothermolysis, which is in my opinion, changed the story of all these treatments for to improve the quality of the skin. Because at that time, as I mentioned, all the treatments were ablative in a full spot, so the recovery time was longer. And he demonstrated that by doing microablative procedures, creating holes in the skin, he could achieve the same effect, the same regenerative effect, with a shorter recovery time. And this really was astonishing. So this changed absolutely the story of all these regenerative treatments. I mentioned dermatologists because they are the father of the lasers in medicine. And we, gynecologists, we learned from them. We applied what they were doing in the skin in the genital area. My experience using lasers dates back to 2006 when I bought my first carbon dioxide laser. At that time, I did a lot of vaginal surgeries and ablative procedures but I had to admit that I had some complications because the ablation was the initial ablative pulse was stronger than the ones we have today, because they were designed to treat the skin, not the genital area. And also I did a lot of laparoscopy with my carbon dioxide laser, hysteroscopy with my ErYag laser, and most of my patients at that time in 2007 started reporting, telling me that after the laser procedure to coagulate an HPV, for example, they improved their vaginal lubrication, or they improved if they were suffering from leakage during an effort. They noticed that leakage was less or minimum, and they asked me if the laser procedure could have some effect on that. At that time, I always said no, and then when I had a lot of patients telling me the same story, I started doing biopsies, and inspired by dermatologists, in this case Dr. Rox Anderson, Dr. Nicola Sorbinati from Italy, we designed different protocols and scanners to start using what they were doing in the skin. They were doing ablative treatment in the skin. We started doing the same at the vagina. In 2007, by the end of 2007, we had done more than 280 treatments, almost 300 treatments, vaginal treatments, demonstrating the regenerative effect of an ablative laser in the genital area. And we presented in 2008 in my hometown in the Latin American Congress of Obstetrics and Gynecology as a non-surgical laser vaginal rejuvenation, because we demonstrated that it was a vaginal rejuvenation. And to the world, in the World Congress of the World Academy of Cosmetic Surgery. Why did I go to this aesthetic congress? Because all gynecological society in general refused the concept of that the laser could improve the histology, the trophism of the genital area. But if you see in this publication of Dr. Marco Gambacciani in Maturitas, after the first paper, peer-reviewed paper, that was our paper in 2011, the following year, 3 years later, a wide array of publication confirmed our initial findings. And it was not up to those years, 2014, 2015, that finally the laser was accepted in all these peer-reviewed papers. My experience with this amazing piece of technology, because I will show you how my practice switched definitely with this non-ablative erbium laser. In 2012, I met this technology in Las Vegas, in the US, in a congress. I was doing CO2 at that time, ablative CO2, and I understood that I could achieve the same results, even better results, by being less aggressive, actually non-ablative, non-aggressive. So I started doing manually with my G set, which is this here. I'm not going to talk about protocols here, specific protocols, parameters, but we can discuss in the question and answers if you want. I just want to focus in the applicabilities and the efficacy of this technology according to my experience and other doctors worldwide. And now Zdenko showed this scanner, which is something amazing because it makes the procedure completely reproducible. So let's talk about the use of this erbium smooth for the management of certain conditions, such as pelvic floor dysfunctions, because we treat patients suffering from SUI, and also pelvic organ prolapse and vaginal atrophy. So I'm not going to talk about urinary incontinence, but we know that 1 in 3 women will suffer some degree of urinary symptoms. It's a matter of time because it's the aging process. Now remember, we're living longer. So we need to be proactive in some way, because gynecologists in my residence, and it's my opinion in the whole world, we are not trained in quality of life. We are not trained to improve our patients' conditions to avoid certain complications in the future. So we have been treating patients mostly with mild and moderate urinary incontinence and severe ones that cannot be operated. But I started using this laser to improve trophism. And then we found that we could also improve the mechanism of continence. We are not curing incontinence, but we are improving continence. So we can treat type 1, which is the hypermobility of the bladder neck and the middle urethra. Type 2, which is the mixed incontinence, because we can combine with some pharmaceuticals, anticholinergic agents. Type 3, SUI, which is the intrinsic sphincter deficiency, because I will show you how we can improve the trophism of the sphincteric mechanism. And if you improve the trophism, you will improve continence. And that is the reason why when you apply vaginal estrogens, for example, or you can improve the urinary symptoms, because all the trigonous area, the bladder neck, the urethra have receptors for hormones. And also to the management of the GSM, the urinary component of the genitourinary syndrome of menopause. So my experience, after having done more than 300 treatments with microablative CO2, these are the two technologies that are supported by the major of the evidence in the literature, mostly the non-ablative Adrian Smooth. But this is for you to understand that you can do this treatment in an aggressive way or in a non-aggressive way. When you do an aggressive way, you make a hole in the mucosa, you are creating a damage, an injury. And as a consequence of this injury, there will be a regenerative process, which could be very effective, but is aggressive, is inflammatory. It's like when you do a resurfacing in your face. If someone here in the audience has done a resurfacing in her face or in his face, you will understand that you will have a 20 days, 15 days of erythema, edema, crust, and certain degree of discomfort. But when you do a non-ablative Adrian Smooth in your face, for example, in your body for tightening, for stimulation of collagenesis, or if you do in the vagina, you will see that the improvement will be by far superior because you don't have downtime. And this is the most important thing for me, to my patients. I don't want complications. I don't want downtime. So I decided to start doing this like cooking a steak. You see, you push temperature deeper and deeper. Zdenko has showed the mechanism of action. I will highlight the most important topics about this. So why Adrian Smooth for GSM and pelvic floor dysfunction? Because in my opinion, is the safest type of laser to induce thermal tightening and remodeling of the connective structures of the vaginal mucosa that create vectors. And this is important because when the mucosa shrinks, all the surrounding sanguine structures will be pulled. And this is the reason why lasers, this type of non-ablative lasers, are used amazingly to improve the flaccidity in the body or in the face. So giving support to the urethra in this case and the bladder neck and improving the trophism. So not all the lasers are equal. Sometimes when I go to a congress and a doctor says, no, for example, incontinence or severe or moderate stress incontinence, lasers will not work. I raise my hand and I say, excuse me, which type of laser? Because not all lasers are similar. Not all ErYag are similar, not all CO2 are similar, because we have to talk about not only wavelength, but also pulse duration, because the result, the outcome, the laser tissue interaction, the effect is not equal. I will give you an example. You can use an ErYag laser with a short pulse to destroy hair follicles, hair removal, but you can use the same laser, the same wavelength, but with a longer pulse to promote a stimulation of the hair growth. So with the same laser, you are achieving two
oppose two different results. How come? Because it's the pulse duration. According to the pulse duration, you can destroy or you can stimulate. And this is very important because when you talk, for example, about ErYag laser, you have to specify which type of pulse are you using. We are using the longest pulse on the market, which is the Fotona Smooth or the Adrian Smooth. And this is what Adrian Smooth can effectively achieve. First, a fast heat shocking, which will be responsible for the turnover of the epithelium, promoting the release of non-inflammatory growth factors, because we are not making injuries here, such as, for example, transforming growth factor beta 3, which is non-inflammatory. And then the standard slow thermal stimulation will be the transmission of the warming process to the deeper layers in the mucosa, as Zdenko said. So this is like cooking a steak, basically. Laser energy is delivered onto the mucosa in a fast sequence of low fluence laser pulses inside an overall super long pulse of several hundred milliseconds. So when the temporal separation in between pulses is longer than the thermal relaxation time of the surface tissue, then the tissue has sufficient time to cool down between the pulses by dissipating the heat into the deeper tissue layers. And if at the same time the laser energy is delivered in a period that is shorter than the thermal relaxation time of the total mucosa, then the deeper layers does not have time to cool off during the laser pulse sequence. Thus, the delivered laser energy results in an overall non-ablative buildup of heat and create temperature increase in the mucosa. And this is what we want. We need to increase temperature in the mucosa, not deeper, not beyond the mucosa. So be careful. When you use a laser, you are being selective. And when you use this type of laser, you are being just targeting the water of the mucosa. And ErYag is the most absorbable in water, and this is the reason why I can increase temperature only in the mucosa. It's the only tool that gives us the possibility to be selective. When you use a radio frequency, when you use an ultrasound, you are not being selective, you warn everything. So when you do this dual action, you will have initially you will have a vasodilation due to the photothermal effect. I will connect my laptop. Photothermal effect, vasodilation, because there will be a release of bradykinin, histamine, which will promote a relaxation of the precapillary sphincter, improving or increasing the supply of oxygen and nutrients to the treated area. And this is what initially will start promoting the reversing the lack of vessels, vascularization, and atrophy. And then you have the second effect, which is the thermomechanical interaction. The laser breaks the peptide bonds of these mucoadhesive proteins, which maintain the fibrillar structure of the lamina propria. So we are promoting a collagen denaturation, and as a consequence of this, there will be a tightening in the collagen fibers. You are creating vectors that will pull the mucosa, and all the surrounding sagging structures will be pulled, as in this case, where the fascia has been detached from the insertion because there is damage. So in patients with multiple deliveries, the levator musculature is weakened and the fascia is thin, elongated, or detached from the lateral pelvic wall. So this will be pulled, and this is the reason why initially you will see an improvement in urinary symptoms. A wide array of publications demonstrating the regenerative effect, the restorative effect, these non-ablative pulses of long pulses or super long pulses of ErYag have been published, demonstrating penetration, thermal collagen denaturation at between 200 to 400, even 500 microns below. And this is just to show you in the skin what can we achieve in the skin. And we are now conducting a research in our university with immunohistochemistry in the skin and in the vaginal mucosa, demonstrating that we can go even deeper even deeper. But we need to stack shots in order to be able to push temperature deeper and deeper. I will show you some of our preliminary results, because all these papers talk about, in general, between 200 to 350 microns. And we have demonstrated activation of fibroblasts with antibodies for procollagen type 1 with immunohistochemistry up to 2000 microns. So these procedures arose after observing the amazing results that can be achieved using non-ablative ErYag smooth laser applied to the oral mucosa for the treatment of snoring and sleep apnea, which is very popular treatment worldwide. So you create a tightening, you improve the flacidity of all these soft palatar, and the patients improved. Also in the face, for aesthetic purposes, this laser, there is a protocol called Fotona 4D, which is pretty popular also around the world, in Latin America, in the US, where the oral mucosa is, as you see here, is being treated directly through an adapter or directly with the handpiece, creating a building up of temperature. And you see how you create vectors, and in the future the quality of the skin also improved, because you are creating vectors like if you were using a filler or threads or any other injectable. But here is without any injectable, just laser. So after seeing this, all these applicabilities in gynecology, really, if you consider this effect, photothermal and thermomechanical effect, this effect makes sense that what we are doing in the genital area, and what we are doing in the genital area, we are improving our patients' quality of life. We are not treating prolapse, we are not treating patients with incontinence, we are improving their quality of life, which is without surgery, which is something even more important. Because all these patients, you know, when you do a laser, or when you do in aesthetics the application of botulinum toxin or a hyaluronic acid with aesthetic purposes, you know that you have a duration of the effect that can be 4 months to a year, depends on which product you can use. When you use a laser, even when you use this type of laser, such as the Fotona Smooth, which it has, in my experience, the longest effect on the market, because with 3 sessions I have patients that have been with a good result for 2 years. But I have patients also that need sessions every 4 months or 6 months, depends on the case, such as this prolapse here, for example. This patient having this severe prolapse is a recurrence after surgery, but she didn't consult me for the prolapse because she was accustomed to live with the prolapse. She consulted me because of dryness, burning sensation, itching, and I can show you here how, with the combination of trained muscles to treat the perineum and with the laser ErYag Smooth, we improve the trophy definitely. The dryness disappear, the burning sensation disappear, and even the prolapse improved. These patients here is for surgery, because sometimes surgery cannot be helped. But what if we would have started earlier doing a laser, something proactive, when you have a vaginal relaxation before having prolapse? This is the concept that I want you to live with. If I have to leave you with a concept, is that you have to consider your patient quality of life when they started the aging curve. That is the best moment to treat a patient. It's like in aesthetic. When you can achieve the best result? When you do a laser in the face, for example. Ask a dermatologist. The sooner the better, because the skin will be stimulated. And when the skin is stimulated as the vaginal mucosa, you are promoting a restorative process. This is regenerative medicine. My experience using laser, Fotona Smooth laser, ErYag Smooth for management of stress urinary incontinence, in my practice, what we do, it is very important to use the before and after picture. Here you will have photos. Our before and after is the evaluation of the subjective improvement and the objective improvement. It's very important to use questionnaires such as this one, ICIQ short forms, which is a validated questionnaires with 3 simple questions that will show you how your patients will be improved. More than 80% in our practice. After 3 sessions, 1 month apart, and then a touch-up session every 6 months or every a year, depends on the case. And then you see the voiding diary. We use the 3 days voiding diary where we can show you, and my patients, they do it at home, and they see how they improve the voiding frequency, the liquid quantity, and the liquid frequency. And the objective evaluation is done by our assistant in our clinic. We use the 1-hour PAT test, which is very simple to be performed. You need these tools just to wait the path before and after drinking the water, half liter in 15 minutes. You wait an hour, and then you make your patient do some efforts, and then you wait the path. And you will see how this can be improved amazingly. So this is our before and after. When is the best moment to perform these lasers to treat the manifestations of pelvic floor dysfunction? My answer is, the sooner the better. Why? Because if you wait until your patient has a severe incontinence, a severe prolapse, or even moderate or severe, well, sometimes surgery cannot be helped. So be careful. You have to address what we call vaginal relaxation. We never been taught about what is vaginal relaxation. If you go to a surgical a book of surgery, vaginal surgery, you will find the normal pelvis anatomy and the prolapse and the incontinence. There is no chapter talking about vaginal relaxation. We don't have experience to manage the vaginal relaxation because we do not consider this as a pathological or a future pathological continuous process. And believe me, when you have a vaginal relaxation at the age of 40, that patient, if there are in the future other risk factors, may develop symptoms of pelvic floor dysfunction. So this is the most important thing to be considered. Also with the aging, genital aging, we will have atrophy in the vaginal mucosa, atrophy and relaxation of the pelvic floor muscles, and relaxations and weakening of the connective suspension structures. If you do a POP-Q analysis to all your patients after 40 years old, you will see that 9 out of 10 will have certain degree of vaginal relaxation. You have to measure and you have to diagnose the vaginal relaxation. When you have vaginal relaxation, that, in my opinion, is the best moment to start offering regenerative treatments. Now we have regenerative options. When I started using laser, we never talked about regenerative gynecology. Also for the GSM, we understand, we know what an atrophy is. Gynecologists are very familiar with this umbrella under which we can group symptoms derived from vaginal atrophy, such as this one, and the urethral atrophy, because also the urethra will be affected. There will be diminishment in the blood flow, shortened urethra due to atrophy, diminishment of urethral epithelial and mucosa thickness, diminishment of periurethral collagen. All these changes could bring the possibility of symptoms such as dysuria, frequency, urgency, and even incontinence. So when you have an atrophy without symptoms, you should treat that patient, because if you improve the scenario, you will decrease the possibility of future symptoms. And if you compare the incidence of this condition, urogenital atrophy after menopause, with other disease, you will see that 100% of our patients will suffer urogenital atrophy. It's a matter of time. And 45 to 50% of them will have symptoms in the future. Compare this incidence to osteoporosis, severe osteoporosis, breast cancer, etc. And now people living longer, we are having more consulting women nowadays affected by some of these type of symptoms. And men having Viagra, there is a problem. We are facing a future problem in the sexual problem. So to diagnose a vaginal atrophy, we don't need any special study. We understand what is a vaginal atrophy is. We have to examine our patients, but you can use a pH or the maturation index evaluation or the maturation value evaluation, which is very simple because this is cytology. You measure the amount of the percentage of cells, and you will do the diagnosis, or you measure the vaginal pH, and you know that between 45 to 5 is normal, and with the menopause, because there is no glycogen, the pH tends to rise. So the evaluation of the maturation value and the vaginal pH represent a key guide for the diagnosis and management of a woman with urogenital atrophy, regardless of the presence of atrophy symptoms. What are we doing now if the patient doesn't have symptoms? We are doing nothing. So we are waiting for the patient to suffer to offer them estrogens. So this does not make sense. This is not regenerative gynecology. Regenerative gynecology is that you have to start being proactive to your patients. If you have your patients once a year for a check, for a checkup, for a pap smear, etc., and if you have your laser, you should do one session when you see the atrophy, when you see the vaginal relaxation. Otherwise, in the future, if the patient is suffering from symptoms, you will need more than one session. You will need 3 sessions initially, and then to see the results. So why wait until they have symptoms to offer a treatment? This is my question. Look at this patient, this lady with a precoce menopause, 39 years old. Look at what happened. She consulted to me having this lesion. This lady, initially when she had the menopause, if she had consulted to me before, I would have started the laser, and probably she wouldn't have been suffering from this now. And this is after the treatment. Or this one, 59-year-old woman, came to me after, look at this severe atrophy. Look at the pale here, the wound and the pale. I did a biopsy to rule out malignancy, and then I started using my laser. But if this lady would have started at the age of 50 doing an annual session, she wouldn't have been suffering from that for 10 years. This is regenerative gynecology. So why laser? Because laser is light. Light is energy. And according to the first law of thermodynamics, the energy cannot be destroyed, rather transformed, creating nor destroyed, rather transformed into heat. And the heat will make the photothermal effect. Last year, we published in the Climateric Journal the outcome, the changes that we can achieve in the epithelium, in the mucosa, in the lamina propria, using this erbium super long pulse smooth mode. We did biopsies from one side in the vagina before the treatment, and we sent this to the histology analysis. And after 3 months and a complete protocol, we did 3 sessions. We did the biopsy to see the improvement from the left side. Personally, I love to see all these changes, and I've learned a lot from my pathologist. I've been doing biopsies for research for all these years with different pulses, and I have to admit that with only one session with the Fotona Smooth, you can switch your maturation value from 10 to 55. Remember, less than 50 is atrophy. More than 50 is proper trophism. The ideal trophism in young ladies are more than 65. But look at what happened, because this is a lady that I show you with a severe prolapse. You see the metaplasia, you see the keratin here with a very thinner epithelium. Look at what happened here. The keratin switched to glycogen. And you see here, this is a basal cell hyperplasia. And this was achieved with only one session. But this is another example. Look at the improvement of the amount of layers of cells and the thickness of the epithelium. A bunch of cases that I have done demonstrated the regenerative effect that you can achieve by being non-aggressive. This is the concept. This treatment has to be, first, we look for the safety, and then second, the efficacy. And this is after my almost 15 years using different pulses, different wavelengths, I finally can say that I am working with the safest and the more effective technology on the market when it comes to lasers. Look at this trichromic, the Mason technology to show you the improvement in collagen, and also the new fibrillar component that we can find, and the vessels in this before and after, not only vessels but also the congestive effect after the treatment. You can see here in the after the complete protocols, red cells inside the vessels. This is congestion, and the congestion will give us will tell us that the effect will last at least for 6 months if you can achieve basal cell hyperplasia, papillomatosis, a congestion, not only vasodilation. Well, we are now conducting a new research that hopefully we can publish next year. Immunohistochemistry of the vagina, after Adrian Smooth in postmenopausal women with SUI. So you can see here the activated fibroblasts with antibody for procollagen type 1 that is marked by the red arrows. And this is at 600 microns here, because we are testing different pulses, different fluencies, different number of stacks, and trying to find which the best penetration can be achieved. We published in 2006 our paper showing the efficacy in comparison with the standard treatment, which is striol. We use striol, vaginal striol, and we measure dyspareunia, irritation, chronic leukorrhea, dryness, maturation value, and pH value. And we presented this in FIGO in 2007 in Rio. And definitely we treat the patients 2 months with 3 sessions of the laser and 2 months with local estrogens, and then we measure how long this effect could last. And if you compare here, we have up to 18 months effect with the laser, and the estrogens completely disappear in 6 months. So this is very important to be highlighted, because you can be proactive without hormones. And now women having this cancerophobia worldwide, in my country, women refuse, the majority of them refuse to receive estrogens. So what other tool can we use? Well, laser, non-ablative laser with the longest pulse is the best option. This is just to show you that what we have been doing lately, testing pulses in the skin and in the mucosa. And this is the neck, and this is the abdomen, and this is the antibody for procollagen type 1, and the way we measure up to 2000 microns, and how we can penetrate up to 2000 microns. This red arrow is marking a positive fibroblast, and this black arrow is marking a negative fibroblast. So not only more fibroblasts appear, but also a positive fibroblast. So this is what we are doing now. As Zdenko showed, we developed in 2000, we started using this thanks to Fotona, who believed in the idea that the trophism of the urethra could also be improved through a very shallow warming process. Fotona created this intraurethral cannula, which is a 4mm cannula that can develop the energy circularly in the urethra very superficially. The effect is no more than between 30 to 40 microns, so very superficial. But what we are looking here is not tightening. We are looking for vasodilation. We need to promote a congestive effect in the submucosal vascular plexus. If you remember the sphincteral mechanism of continence, you have a rhabdosphincter and the intrinsic mechanism. The intrinsic mechanism has the thickness of the epithelium, the lamina propria, and the submucosal vascular plexus. The urethra has this steri appearance to give to the urethra the possibility of coaptation and closure. So we need the muscles and the trophism. That is the mechanism of continence. So it is important to understand here the role of low urethral mucosal and submucosal blood perfusion in patients with GSM. So the urethral atrophy will occur to a certain degree in all patients with GSM. There is no way. So the appearance and recurrence of urinary symptoms is attributed to inadequate pressure transmitted from the mucosa and submucosa to the atrophic urethra. And this is very important because the appearance of symptoms will depend to the pressure transmitted by the radiosphincter. Mostly the determinant factor is the state of the submucosa and mucosa vascular plexus. So at the beginning we considered the Laplace law, in which if you reduce the radius, there will be more tension in the wall. So the better the trophism, the more concentric pressure inside the urethra will exist. An example could be illustrated if you try to catch water in your hand by making a fist. No matter how strong your muscles are, if you don't have trophism, the water will spread in between your fingers. So this will similarly happen if you have good muscular mechanism, an appropriate muscular mechanism, radiosphincter, bladder neck, and middle urethra support, but you don't have trophism. And this is the reason why when you prescribe your patients vaginal estrogens, urinary symptoms tend to improve, because due to the atrophy, there is between a 5 to 30%, according to different data published, loss of effectiveness of the mechanism of urethral closure. We presented in 2015 in ICS, demonstrating the improvement, how you can improve with 2 sessions your patients suffering from intrinsic sphincter deficiency. The procedure is quite simple, painless, no anesthesia. We develop 4 shots every 2.5 millimeters of this cannula, doing 4 passes. Remember, the length of the urethra is no more than 5 centimeters, between 3.5 to 5 centimeters according to the age of the patient. Although an adequate performance of the radiosphincter is important, the key factor that will determine continence is the trophism of the mucosa, submucosa vascular plexus. Trophism of the mucosa and the submucosa vascular plexus. This is the reason why we are combining in elder patients and mostly after menopause, the vaginal approach and the urethral approach. And Fotona is the only laser on the market that offer me as healthcare provider the possibility of these 2 approaches. We published in 2017 our first paper. We demonstrated how we can improve the trophism of the urethra, even doing biopsies at the level of the bladder neck. There is no possibility of stenosis, urethral stenosis, because you are using just only 4 millimeter cannula, and you are doing a very shallow effect. Look at this before atrophy, a thinner epithelium, no vessels in the submucosa and mucosa. Look at what happened after 2 sessions. This is the so-called smoothness of the internal wall, which is the thicker, the improvement of the epithelium, the transitional epithelium in the bladder neck. And look at the amount of vessel with red cells inside them. So the congestive effect and the angiogenic effect is amazing. In 2018, we published another paper in the Red Journal in the United States demonstrating that we can improve the urinary component of GSM using only urethral laser. Urgency, dysuria, frequency can be treated through a urethral approach if there is no need to do a vaginal treatment, because we do a vaginal treatment to improve mostly vaginal conditions and also urinary symptoms related to stress incontinence or urgency in younger women, but in elderly women, also women suffering from recurrent urinary infections. When you improve the urethral trophism, you are diminishing the incidence of recurrent infections. And this is a future indication also that we are seeing in the horizon. So the intraurethral laser, the so-called Incontilase intra, main indications are the management of the type 3 stress urinary incontinence, the intrinsic sphincter deficiency, the urinary component of the genitourinary syndrome of menopause, and to improve continence by improving the performance of sphincter, mostly after menopause. And To sum up, and this is to conclude my presentation, the gynecologists pioneered the use of laser in medicine. And now we have been using laser for laparoscopy, stereoscopy to treat HPV, ectropion, condyloma, vaginal candidiasis, mostly recurrent vaginal candidiasis, because remember the effect that the ErYag Smooth has a fungicidal and fungistatic effect demonstrated. We are conducting another research that we are looking forward to seeing this paper published next year. Vulvar pathology in general, vaginal relaxation. This is the regenerative field. Vaginal relaxation, pelvic organ prolapse, urinary incontinence, vaginal atrophy, and also for surgery, labiaplasty, also to improve certain conditions such as ligament sclerosis, to destroy pigment, labial melanosis, vulvar hyperpigmentation. Also for aesthetic purposes, we use ErYag for lipodystrophy of the mons pubis, recurrent vaginal candidiasis, I have just said, folliculitis, pleasure enhancement is another protocol that we have been working and to improve the clitoral sensitivity, scar tissue, hair removal, vaginismus. So there are a wide array of applicabilities that I'm performing in my daily practice. According to the data published, there is a lot of papers, as Zdenko said, in using this technology in gynecology, more than 70 papers in peer-reviewed journals, but still in the United States, which I don't know which is the reason why the FDA have not been approved yet. For them, there is a lack of long-term randomized control and prospective studies with large number of patients to better address the use of energy-based device in general. But believe me, ErYag Smooth, in my experience, after used all wavelengths on the market, is the safest and the more efficacious technology for my patients. And thank you very much. This is my email, my Instagram. If you want to contact me, I will be very glad to be of help.
Thank you, Dr. Gaspar. Very nice presentation. Now, moving on to Q&A session. I see many questions here, and Zdenko already answered one, so we can move to the rest. Hope we can answer all the questions today. I think the first one is how incontinence severity at baseline and the number of laser intervention affect success rate, and whether the effect of laser therapy was obvious 6 months and 2 years after the last laser intervention. Perhaps this could be addressed to both speakers. Please, Zdenko or Adrian?
I could answer according to my experience and according to the data published. The degree of the severe of the incontinence, it is important also. As I said, the sooner the better. So this does not mean that you cannot treat patients with severe urinary incontinence. But you have to explain them that when you have a severe urinary incontinence, the standard option of treatment is a surgery. But there are a lot of patients that refused initially undergo a surgery. In my practice, when I say, listen, you have a severe urinary incontinence, I would strongly recommend you that we do a surgical procedure. But 1 out of 3, the answer, I understand, doctor, that this is severe, but I know that you are doing laser because you did a treatment to one of my friends and she's so happy. I would like to know if I could give it a try. And I say, okay, we can give it a try, but remember that your friend has a moderate or mild incontinence. Again, what I want to say is that you can do, because this is non-ablative, you don't need to do a urodynamic study to do this treatment. You don't need to do any special preparation. You can do the treatment also to improve the trophism in severe patients. And then you can do combined with surgery. And I have patients that even after surgery, I use the intraurethral approach and the vaginal approach to improve trophism, both urethral and vaginal trophism. So because when you do a sling, the standard option of treatment, there are some patients that still have frequency, urgency, so because surgical procedures doesn't improve trophism. So be careful. You can offer this particular treatment to any of your patients as long as you are able to explain them what you can improve and what you cannot improve. And remember, the earlier, the better. How long the effect can last? If you do the 3 sessions, average a year. And then the touch-up will be in relation to the case. If you have patients suffering with severe risk factors, I prefer to do 1 session every 6 months as a touch-up. But if you have a younger patient with a moderate or mild incontinence, I do 1 session a year. I do not repeat the 3 sessions. I do 1 session a year.
Okay, thank you. Maybe Zdenko?
Yeah, I can give a comment. There is actually a study, and I can send a copy of the paper, or maybe even I can share the screen and show the study. There was a study done in Germany and Switzerland by a group of our users, which were observing how the number of sessions and also how it is influencing, in fact, the duration of the effect. So they showed out that it is connected. So if you do more sessions, you can prolong the effect. And they did up to 5 sessions. So prolongation from 3 sessions to 4 were quite significant. From 4 to 5, not so much. But in fact, it goes exponentially. So as more as you're doing, less and less contribution you are getting. So for example, at the beginning, we all hope that a single session will be enough. But then we discovered that certain percentage of patients needs at least 2nd session. And then by time we established 3 sessions as a rule. So for majority of the patient, there will be effect, and this effect will last in dependence of the patient age and genetics and collagen quality. It will last between 1 year and up to even 2-3 years, in some patients even 3 years. But percentage of this patient with 3 years lasting is maybe 5-7%. With 2 years, maybe 25%. And for majority, it's 1 year. So it's individual, but it is in average quite good. So as Adrian said, doing 1 maintenance treatment per year is for a lot of patients, most of patients, very acceptable. So that's how it works. And regarding the number of sessions, one more detail maybe, when we are doing prolapses, and especially larger cystoceles, we intend to do more than 3 sessions. We are doing usually, if needed, up to 5-6 sessions for prolapses. But for atrophy and incontinence, in average, it's 3. Also, another moment is that we started and also recommend to do both approaches, intravaginal and intraurethral. Because if you don't take a urodynamic test for the patients with incontinence, you don't know if they have intrinsic sphincter problems or not. You know that they have stress incontinence, but it can be in let's say 15% of patients to 20% of patients, it can be ISD problem. Without urodynamics, you don't recognize them. So it can look as a failure of treatment after vaginal treatment, but if you apply also intraurethral, then you can also improve these patients. So we noticed this. We are doing now a randomized controlled trial in Canada, in which we have one group just intravaginal, the other just intraurethral, and the third group with both. So we expect this study to be finished during this year and maybe next year to be published, and we can show then on a real good study methodology, we can show the influence of both of the approaches. But already now, according to our experiences from last 5 years, 6 years after introduction of intraurethral, we suggest people to do both. If they have both, to do firstly intraurethral and then intravaginal treatment in the same session. It will prolong the session just for 10 minutes, and it will improve the total result.
Okay. Okay, thank you, Zdenko. Moving on to the next question. Stress urinary incontinence is a common complaint in women after childbirth. So it affects their quality of life and sexual satisfaction. How is the efficacy and the safety of non-ablative ErYag laser therapy in the treatment of SUI and the improvement in sexual satisfaction in Paris women? Maybe Dr. Gaspar?
Well, it's a good question because after deliveries, mostly after pregnancy, because the delivery is like the cherry of the pie. After 9 months having a baby in the abdomen, you see that all that pressure in the pelvic floor can produce certain degree of relaxation. And after the delivery or the C-section with the breastfeeding and inducing atrophy, there are a lot of patients consulting. We have a lot of consulting patients for tightening, for dryness, for sexual enhancement. And it's completely safe, as Zdenko demonstrated through all the evidence published and through the mechanism of action of these special poles, because we are not making holes in the mucosa, and this is for me the most important thing. I remember when I used my CO2 laser in the past, there was smoke coming out the vagina. It was incredible. And when you use a non-ablative erbium, there is no burning, no inflammatory effect. So it's completely safe. And in relation to the efficacy, well, as I've showed you, the tightening effect and the improvement on the trophism is incredible. Initially, you will have an improvement in trophism, and after the 3 sessions, you will see a tightening. The tightening can be seen immediately in younger women because they have a good hydration of the mucosa. The erbium is more absorbable. And then this is the reason why the tightening could be seen even from the very first session. In the older the patient, the tightening needs probably, you have to wait between 2 to 3 sessions, or even the 4th session, a touch-up is needed. And sometimes when you have a severe dehydration of the mucosa, because after menopause, this is not valid for women after a delivery, but after menopause, when you have a stress incontinence or severe prolapse and you want to do this technique, you can do it, but be careful. I strongly recommend you to prepare the mucosa first by using short treatment of estradiol, for example, estrogens. 1 week of estrogens will improve the water retaining ability of the mucosa. So if you wait 1 week, you improve the water retention, and then you do the laser. And you will see that the effect in terms of tightening would be by far superior. This is not valid for younger women but if you have immediately after the delivery severe atrophy, in that case, what I do 1 Renovalase, which is low fluence to improve trophism, and after the first session of Renovalase, I do the Intimalase. 1 month after, I do the Intimalase. So I have a better trophism to maximize the result of the tightening effect.
Okay. So, Zdenko, you want to add something?
Yeah, I would just concentrate on this sexual gratification improvement. So we call this protocol Intimalase. We didn't mention the name of protocols before. So for incontinence, it's Incontilase. For the atrophy, it's Renovalase. And for laxity and the sexual pleasure, it's Intimalase. We also have Prolaplase. So there are 4 protocols, different protocols for treatment of different indications. So Adrian was talking about vaginal relaxation syndrome. So this vaginal relaxation syndrome now people also call vaginal laxity. And with Intimalase protocol, we are actually reducing it and improving sexual gratification. And it was measured in several published studies. Just recently, last year, there was also one study from Egypt where the pelvic floor exercises were compared with the Intimalase. It was a randomized controlled trial and showing very good results for erbium. Also, some other studies were done already from 2012 on. I think at least 6-7 studies were published. One in which I was participating was also from Japan, where we have a 2.5 year of follow-ups and very good results there as well. So people improve definitely their quality of sexual life. Of course, this is just one component. As you all know, there is many factors which are influencing the sexual gratification. But what we can assure is that we will make the vaginal canal tighter and also firmer. The tissue will improve, and this is a precondition for later sexual gratification. And also the questionnaires which are used, they are measuring it. For example, a big group of Italian doctors led by Professor Gambacciani, they were analyzing the improvement of sexual life in more than 1,000 ladies in Italy, observed with the two different questionnaires. One is FSFI, this is Female Sexual Function Index, very common one. And the other was FSRD, it's a sexual distress questionnaire. And both of them showed significant improvement after 3 sessions of treatment, lasting at least 1 year, if not more.
Right, and it's also completely safe because it's non-ablative.
It is safe, and as I mentioned at the end of my lecture, it's also not how to say, in any way risky for the ladies which are in between the pregnancies. So younger ladies can do this treatment and then they can get pregnant and have normal delivery, which you cannot have after slings, of course. And the tissue is even better because tissue gets stronger through this process.
Okay, thank you. For next question, we have 3 questions here, I think. Oh, 4 questions from Dr. Fernandi Mugni. He's our urogynecology consultant in Indonesia and also a former speaker, I think, in the last Fotona webinar. He told me that he want to ask to you, Adrian. He want to discuss many questions. It turns out he asked 4 questions here. The first one is, for gynecology, do we have to use ErYag also?
Okay, well, in my experience, I'm not using ErYag laser in the vaginal area. I use ErYag for other indications. I'm treating, for example, lichen sclerosus. I'm also treating, I use it for aesthetic purposes to do a laser lipo of the mons pubis. This is the hair removal of the genital area. We use ErYag, but I don't need to use ErYag in the vaginal area. ErYag, be careful because it targets the hemoglobin. You can go up to 7 millimeters deep in the mucosa. Could be effective, but could be more dangerous, as in the face when you use aesthetics. Erbium is completely safe, and we have a lot of evidence that erbium works perfectly. So I don't use ErYag.
Okay.
Maybe just a comment from my side. In our systems, we offer either single wavelength or both wavelengths, and ErYag, neodymium YAG, is very useful for many indications. Adrian mentioned some of them, and we have also published papers with very good results, for example, for lichen sclerosus, treated with ErYag in a minimal invasive way. ErYag can penetrate deep, but with the special modalities of delivering this energy, like one which we call piano, it's very safe to be used. So it's not dangerous even for vessels. Of course, ErYag is also used for occlusion of the vessels, for example, on the face or leg veins and so on. But this is another modality. Then you have a very strong pulse, which will coagulate this blood. But if we use it in different way, with the piano mode, which is very gentle, we can achieve an excellent improvement of not only lichen. Now we start to treat vulvodynia as well. And then there are other applications, like he mentioned, hair removal and so on. So ErYag is a very versatile laser. I would suggest people to have the combined system because it will open some new possibilities for applications which erbium cannot do. It is true that Dr. Gaviria, Jorge Gaviria, who was lecturing on the last symposium, he did some trials also with use of ErYag intravaginally. And his results were showing a certain contribution to the overall result. But his protocol was not still fully clinically validated that we can also confirm the safety as we can for the erbium YAG. Because of course you are going then, let's say, 2 layers. The upper layer you treat with erbium YAG with 500 microns, and deeper layers you can reach with neodymium YAG. But then of course you have to know what you are doing. Your protocol should be bulletproof regarding the safety. And maybe we will introduce this in time. But in this moment, our focus is on a superficial treatment of like lichen and vulvodynia and some other stuff. Otherwise, very useful wavelength.
Okay,
Yeah,
noted, Zdenko.
in fact, I use Antiaging in my practice.
Okay. So next question, it's about the SUI symptoms or the urinary symptoms of GSM. Do you always use intraureteral laser to treat any urinary symptoms of GSM? And then I think we can combine this with the next question. In your experience, for most cases of SUI, which is seemingly mainly just because of the hypermobility and not because of the intrinsic sphincter deficiency, do you always use intraureteral laser? Please.
Well, normally the intraureteral approach is a must-do when you want to improve the urethral trophism. Basically, that is the main indication. For example, if you have a patient suffering from urgency, dysuria, infections, and she's an old lady or after menopause, and when you improve the urethral trophism, you will have an amazing outcome. If you have a severe incontinence, for example, an intrinsic sphincter deficiency in a younger lady, let's say, I remember having a patient 23 years old, 23, that after a delivery, a surgical delivery with forceps were used, she started suffering after we did the urodynamic and uroflowmetry study, and we determined a valsalva liquid pressure less than 20 water centimeter. So a severe incontinence with an intrinsic sphincter component deficiency. But the problem was the muscles, the rhabdoid sphincter was damaged. That was not a problem of trophism. So because she was young, it has nothing to do. So when you have an old patient, or you have to improve the trophism of the urethra, because remember, the mechanism of continence in women, the trophism of the urethra is mandatory to be improved because you will improve continence. So to answer your question, when I use the intraureteral laser, mostly after menopause, not in younger women, unless you have demonstrated that you need to improve the urethral trophism. It doesn't matter the condition. It doesn't matter if you have urgency, frequency, incontinence, stress incontinence. If you improve the urethral trophism, your results will be superior.
Okay. So, one more question from Dr. Fernandi. So, from your experience, does laser could treat also the severe SUI with the post-treatment target is dry? Maybe it means normal. So not just improve, but back to normal. Is it possible that way? How bad the severity of SUI that could be treated by laser? Or until it is so bad that would only can be treated by sling surgery?
Well, when you have a severe, again, as I said before, when you have a severe stress incontinence, the number one option of treatment, level 1 evidence with the degree of recommendation A is surgery. You have to say this to your patient. Then you have the non-surgical management of the pelvic floor dysfunction that will be used in case that patient refuses surgery, or you want to combine, you want to prepare the patient for the surgery. I have patients that they suffer severe incontinence. With the laser, they improve 1 degree, and they consider that a good result for them. And they stay with this moderate incontinence, doing laser every 4 to 6 months, 1 session, and to put off surgery for any reason. This does not mean that you cannot do surgery, a surgical procedure in the future, but you have to explain this to your patient. So my experience is this. A laser is a tool. You can combine this tool with the surgery, but when the surgery is indicated, you have to offer this standard treatment to your patient. But this does not mean that you cannot do first 3 sessions of laser and then do the surgery, or put off the surgery.
I would just like to add a comment. One of the first studies we did here in Slovenia on stress urinary incontinence, it was a lot of patients, like 175 patients in this study. our initial criteria was mild and moderate only, but somehow these investigators, they took in also the severe patients. So we had, in fact, the majority of the patients were severe according to the categorization by ICIQ questionnaire. And I was a little bit concerned because I thought the results were not be so good. But in fact, we got relatively good results also for severe incontinence. And this is the question also of the quality of the collagen of the patients. So some patients, they can have a severe incontinence, but they have good collagen. And then this treatment will improve it a lot. So some of these patients even get dry. Not all, of course, but improvement was in all of them. And if you're looking into grading, a lot of them change for 1 grade at least, going from severe to moderate. And I remember some oldest patient. In fact, the oldest patient in Slovenia I know about was a 91-year-old. She was in a nursery home, and she had such incontinence that she was all the time on diapers, on pads. So, of course, it was tricky to claim that you will make her dry, but she wanted to get the treatment. And the doctor did it, and she improved from I don't know how many pet to just 1 pet per day, and she was extremely happy. She said, "Now I can live with this." Also, we got a kind of video testimony from Korea, where 89 years old lady was telling about her experience. Her son took her for this treatment, and she got dry after, I would say, moderate stress incontinence. So it is. In a way, it's a relatively individualized result, although we have these average values which are showing like 70 to 80% improve significantly. But if you look each person individually, you can get some surprising results also in the categories which otherwise you will say it is not for that.
Yes, okay, noted. For the next question, it's from Dr. Sony. It's also one of our urogynecology consultant here in Indonesia. He asked about, do you have experience in treating urinary incontinence by laser therapy in aging women?
Yes, yes, I have.
And the oldest that you have treated?
The oldest I've treated is a lady of 87 years old. Okay. And she achieved an incredible result in the combination of a urethral approach and vaginal approach. And up to now, she visits me every 6 months average for a touch-up session.
Maybe just one more comment. When we started with this introduction of these protocols into the practice, we tried to put some limit of the ages, because according to the literature and all the knowledge, people are losing collagen by ages. And what you have in 30s, you have maybe just 1 fragment of this in 80s still remaining in your body. So we put some artificial border on 75 years, and we said, okay, let's say it's for people up to 75. But then, of course, in practice, older people start to come in, and you cannot refuse them. So as I mentioned before, we treated even 90 years old ladies. So we don't put any limit to ages. We just try to honestly inform them that they are poor prognostic factor patients because of their ages, their collagen is weaker, and they don't have so much collagen like younger people.
Mm-hmm. And how about if we compare it with topical estriol treatment? How about the effectiveness and safety of ErYag laser treatment for GSM with an established topical estriol treatment?
I believe yeah.
Oh, sorry. No, I didn't understand. Are you talking about the comparison of estriol?
Okay.
I think this is the question, yeah. The comparison between those two.
I believe Adrian very well answered this question with his presentation, because he showed the study which was published in 2017 or 2016, where he compared 2 groups of patients, one treated with estriol with sessions during first 3 months, and the other treated with 3 sessions of lasers. So improvement with laser was better and much longer lasting than with the estriol.
Yes.
Yes.
Mm-hmm. And
that is.
And using the Incontilase laser, does local anesthetic needed for it?
Not at all. Sometimes in the introitus area, in elderly women, or after menopause, where there is more severe atrophy there, I use 2% or 2 to 5% gel of lidocaine, 5 minutes, but normally I do not use anything.
Well, maybe I can give you an overview of the use of anesthesia all around the world. So it depends very much also on the habits in the countries, because the treatment is very tolerable. I show there that on the pain scale from 0 to 10, the maximal what we notice is 3. It's very tolerable. And this is just on the introitus area. But in some countries like Japan or maybe Italy, they don't want to put any stress to ladies, so they put topical anesthesia on introitus. By default, they don't look into the patients individually. They just use topical anesthesia on introitus, and then they don't have any sensation of pain.
Okay, so I think this is one last question. I think some more is there, but due to limited of time, I think one last question. For most of your experience for postmenopausal patient with GSM, do you advise a combination vaginal and intraurethral laser, or how do you suggest?
If you have patients with urinary symptoms after menopause, I combine both approaches. If you have patients after menopause only for vaginal dryness and not suffering from urinary component, I only use the vaginal approach. But let's say dysuria, frequency, urgency, do not talk about incontinence. It's more common to have a frequency, urgency. When you combine after menopause, the two approaches, the results is incredible. Incredible.
Mm-hmm. Zdenko, maybe you have a last say on this?
Well, I would say so far we have, I don't know the exact number, but thousands and thousands of lasers out there. I would say altogether maybe 10,000 doctors already worked on all of these 1,000 lasers. And majority of them are doing just intravaginal treatments, because our introduction of intraurethral was later. And now it is coming little by little into practice. So we don't have a huge number of users of intraurethral yet, but the advanced user, like is Dr. Gaspar and some of other advanced users, they are very happy with intraurethral treatment. And as from the beginning, we thought that maybe it's a little bit more aggressive, and we thought we used anesthesia inside urethra, but through time we discovered it's totally, how to say, comfortable for the patient without any anesthesia. And also the learning curve to insert the cannula inside the urethra is very short. People know how to do it, and the procedure lasts about 10 minutes. So I would recommend to everyone, the handpiece itself is not very expensive, so I would recommend to everyone to go for both. And then according to practice through time to develop the feeling where it is needed to add it.
Wow, okay, thank you. This has been a great discussion, many questions, and fortunately we can answer it all. Thank you again for the participants that has participated in this webinar, and also thank you for the speaker, Dr. Gaspar, and also Zdenko. It's a very straightforward answers, and due to limited of time, I think we need to wrap up. And thank you again to you all. And Fascia, I'll give back to you. Thank you. Good night.
Okay.
Good night. Thank you.
Thank you so much, Dr. Alfa, for becoming our moderator. Thank you so much to Dr. Adrian and also Zdenko. There was a very amazing presentation from both of you. Thank you for answering all the questions from our participants. It is really an honor to have you guys here in this webinar. Thank you so much. Also, I would like to say a little thanks for the participants. Terima kasih untuk participants yang sudah hadir. Saya sudah mengirimkan link untuk diisi. Apabila ingin mendapatkan e-sertifikat, bisa dilihat di kolom chat. Terima kasih untuk partisipan yang sudah hadir pada malam hari ini. Kita dari Fotona Indonesia biasa mengadakan webinar-webinar sebulan atau 2 bulan sekali, dan kita akan menginformasikan untuk webinar-webinar selanjutnya dengan peserta dengan speaker yang berbeda dan juga topik-topik yang berbeda. Terima kasih. Okay, so for you guys, it is not complete if we Do not take pictures. Should we take pictures now?
Okay.
Your best smile. Okay.
Okay.
Pictures. Okay. 3, 2, 1. Okay. Thank you so much, Dr. Adrian. Thank you, Zdenko.
It was a pleasure.
It was a pleasure. Yeah.
Thank you, Dr. Alfa. See
Yes,
you.
thank you.
Bye-bye.
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 Bye-bye. Thank you again, Zdenko.
Thank you. Bye.